Good evening, everybody, and welcome to this fifth in the series of cannabis webinars from SMMGP. And today we're going to be looking at the role of cannabinoids and pain treatments. It's great to have you all here today. I'd like to thank Althea, who have sponsored this series of webinars with a educational grant. All of the content is provided by ourselves and our speakers, but without Althea's input, it wouldn't be possible. I'd also like to draw your attention to the next of the premium membership CPD webinars that SMMGP are running, which is Deanna Jade, who's the founder of the National Centre for Eating Disorders, and that's going to be looking at key themes in eating disorders. So we hope that some of you will be there for that. Now, we've got two excellent speakers today. First up, we've got Sunil Arora, who is an anaesthetist and pain consultant. He works across the whole gamut of pain, so he looks and works with patients with acute, chronic and cancer pain, and he's going to be taking us through some of the technical stuff. And then we've got Lucy Stafford, who's going to be talking us through a lived experience perspective. And Lucy also does a lot of advocacy work around this. So with no further ado, I shall hand you over to Sunil. We will be running a couple of polls throughout this, so please reply to them. And there will be plenty of time at the end of the presentations to put all your questions to both our presenters. So thank you and enjoy the webinar.
Okay, thank you. So I am Dr. Sunil Arora. I'm a chronic pain, acute pain and cancer pain specialist, and I'm here to talk to you about pain and cannabinoids. So we'll just kick off. I've got some declarations. I work for My Access Clinics, which is a subsidiary of Althea. I've also done some talks for Grunthal in the past for tapentadol, and I've also done some talks for medcourses.co.uk. So today I just want to take you through a little bit about cannabinoids, where we are in the UK with regards to cannabinoids, a little bit about pain, just to remind you of the processes, specifically neuropathic pain, because that is where we have most of the evidence for cannabinoids at the moment. And I'm happy to mention some patients that I've dealt with during this time. It's been quite an experience for me. Usually I sit in my sort of tower within a hospital and see patients, and I take them to the place I can normally take them, and then I discharge them back to GPs. But I'm actually meeting some of these patients again, having been through the whole process, and then being able to offer them cannabinoids, which is quite reassuring for myself that there's another option. But we'll crack on just now. I always like to start with this quote. I never knew about pain until I met you. Hopefully you will all leave with such information from myself, but actually that was from my wife. So I'll just move on. I often, with regards to pain, as I said a little bit earlier, I've managed to offer every treatment option to my patients previously. And during the course of my training, I always used to ask them about illicit use of drugs. So do you use anything else? And they often used to say no. But if you ask them about cannabis, they then admit to the use of cannabis. And initially my thought process was, well, I don't know if I can help you with the drugs that I've got to help you with if you're taking cannabis. And I sort of had a little bit of prejudice in my own mind, but I sort of reached a threshold where so many patients were saying to me that they were using it and actually getting benefit from it, that I thought, actually, I need to go out and sort of find out a little bit more about this. So I had to look outside the UK. I spoke to peers about it, and they were quite dismissive about it. And so I had to talk to the rest of the world, and that was Canada and the US. So this isn't actually a graph of where coronavirus has spread. It's actually about who's using cannabinoids. It's a little bit old now, and Althea supplied this slide, but you can see that actually we're behind the rest of the world, specifically the States and Canada, and the rest of Europe is ahead of us, and not surprisingly, the Netherlands are probably ahead of everyone else, and Germany and Italy are catching up. But Germany have some really good processes in and have produced a little bit of evidence for it, and I will present that a little bit later. And I often look back with regards to opiates, because often I have to wean them down, and often in my clinics I'm stopping medications rather than actually starting them. And I just look back in history to see why did we end up where we were with opiates. And one little worry is that, are we doing something else with regards to cannabinoids that's very similar? So I look back with cannabinoids, and you can see that actually there's been a political undertone with why they've been outlawed. And in America, it was to save the DEA as an organization. They were running out of work to do, so that was the reason that America outlawed it. And that political influence went across the pond. And there were a couple of doctors in Ladbroke Grove that got blamed for the prescribing cannabis within the UK, and then because they were prescribing it was outlawed. But previous to that, it had been used throughout the 1800s. Queen Victoria was using it, are the rumours. And so it's always been a medicine that we've just sort of ignored recently. And it is a medicine. This isn't 8 hours old, but the cannabinoids have been approved for two particular uses within the UK, namely for the treatment of spasticity within MS and for Dravet syndrome, a form of epilepsy. So it is a medicine, and like any other new medicine, we often discover new indications for it. And throughout the next 5 or 10 years, I'm sure we're going to discover these with patients already telling me what they're taking it for. Between 1.6 and 1.8 million patients are using this as a medicine right now. And I think that's quite powerful, because how many of those patients have admitted using cannabis to you for medical purposes? And another question comes along is, what are they using it for? So there is data throughout the world of why patients are using this, and actually pain comes up at the top of this. 70% of the world data would suggest that patients are using this for chronic pain. What's interesting during this time is that you've got people are using it for depression, anxiety, insomnia, and also PTSD. And PTSD was actually one of the reasons why Canada was able to legalize cannabinoids. So the soldiers were coming back home with PTSD, and they were using cannabis to manage their symptoms. And because of that, they had a political influence within Canada, and then they were able to get it legalized. And where I work is at Frimley Park Hospital. I see a lot of ex-military soldiers, and PTSD is a huge problem for them. And we've not really had much scope in order to help them, and it feels quite difficult as a doctor when you're not able to offer the help that you possibly could. And one of the other questions is that the patients admitting they're using cannabis has probably grown a lot over the past year, where patients are much more open to it. Actually, even colleagues are saying, oh yeah, I use this CBD spray in order to help my shoulder pain, and nothing else has previously worked. But how long have patients been using this? And if you look at this, actually 25% have been using it for 10 years or more. Nearly 50% have been using it for 5 to 10 years, but 75% have been using it for a year plus. And I don't think there's any way 10 years ago anyone would admit to using cannabis to me ever. I think that's a new phenomenon, and when you talk to the doctors from Canada and the US, they are quite stern in their belief that they're doing the right thing, in the sense that they're giving a medicine rather than these patients getting it from somebody where they don't know what it is. And And this just shows how patients are actually using cannabis and where are they getting any relief from it. There's a little bit of bias here. You're not going to use a medication when you know you're not going to be getting a benefit from it. So the large proportion of patients obviously are going to report a significant benefit, but 10% do report a total relief of symptoms. This graph shows our patients are actually admitting it. And I have to admit, I previously had to push quite hard in order to get those answers. Excuse me. But 50% are worried about telling their GP because of a police point of view. Are they going to get in trouble? The doctor may not approve, and I have to say I was one of those people before, and other people don't think it matters, but actually taking it does matter because it can interfere with other medications. So CBD in particular is metabolized by some of the P450 enzymes, and therefore that can cause problems with metabolism for other medications. So we do need to know as well. So how do they obtain this? Obviously, it's going to be a friend or a street dealer that most of these patients are getting it from. And again, the Canadian doctors are really against going to dealers in order to get it. You don't know how it's grown. You don't know what it's mixed with. You don't know if pesticides have been used. Are there heavy metals in this? And they just don't know what they're getting, which is the other worry for them, along with prosecution. So this is just a quick reminder. If you've been on previous webinars, you would have seen this before, but we've never really had a medication that is able to treat a variety of symptoms, particularly within pain. It's not just pain that's normally a problem. It's normally there'll be a mixture of anxiety, depression, and also there will be a significant amount of sleep disturbance previously. And if you look at the studies into chronic pain, one of the highest risk factors is actually not sleeping well before you get chronic pain. So if you ask the patients, 80% of them would have been poor sleepers beforehand. So if we're able to pick up these patients a little bit earlier and help them manage these symptoms, then there's a possibility that we will prevent them from developing pain. But there are two main ingredients within cannabis that we're able to sort of manipulate right now, and that's the amount of CBD and the amount of THC. So if it's mainly CBD prominent, it's going to help you with your mood disorders such as anxiety and depression. But you also do need a little bit of THC in order to help the CBD work. And if you need something in order to help you fall asleep, THC is the medication in order to help that. And you can get more balanced ratios of CBD to THC in order to help you do that. So just to sort of round that up, you can get something that's very CBD heavy, you can get something that's balanced, and if necessary, if some patients have been taking this for a long time, they may need to be on something that's a bit more THC heavy. But THC is the drug that can cause the psychosis-esque symptoms, but in a medicinal form, we don't get to those sorts of levels. So we're in a really safe realm here with regards to dosage. And this is really interesting. So when you're titrating somebody, it's not like any other drug that you probably have titrated. Maybe some of the pentanoids come close to that, where you start off at a low dose and then you build up until you get your optimal dose. But here, if you speak to patients that are very experienced in taking cannabinoids, they'll be taking their background medication or wherever they're getting it from, and they will get to an optimal dose. But some patients have said, yeah, you know, when I've taken my normal medication, and they might have gone out or they've met some friends and then they've taken some other form of cannabis, they then go into this area where they go into the high dose and they actually get an ill effect from it. So while we're titrating this medication, it's really important we get to this optimal phase. And some of the doctors in Canada and the US are actually noticing that 3 or 4 years down the line, this optimal dose doesn't go up, it actually goes down. So for when we do eventually get shared care going forward, you may actually be reducing someone's cannabis dose because this optimal dose is actually going down over a period of time, which is reassuring when it compares to other medications where you're always escalating what you're trying to give. So what are the common side effects? I think we've all seen the person with red eyes. You walk past them and you can see that they've obviously been smoking something. They may be a little bit more sedated. Dry mouth is very common, and that's probably anticholinergic effects from how it works there. But those are usually the main ones there. And I just want to talk a little bit about going to pain and just remind you about acute and chronic pain in particular. So acute pain is acute pain is particularly acute, but it's less than 3 months is the definition. Chronic pain is when it goes past 3 months' time. And if you suffer from chronic pain, at 50%, if you're still 50% of people who go past 3 months will still be suffering from it in 5 years' time. So it's a really significant proportion of patients. 75% will be suffering at the 1 year phase, but that is usually split up into nociceptive and neuropathic pain. And neuropathic pain itself has traditionally been thought of as either central or peripheral. And we're going to go a little bit more into neuropathic pain because here's where most of the evidence is for cannabinoids at the moment. And it will, I'm sort of convinced it will come for nociceptive pain eventually, and particularly visceral pain, I think, is on the horizon. But with regards to neuropathic pain, it's a worldwide phenomenon. It's approximately 8% of the world population will have neuropathic pain. It's a significant number, and within chronic pain itself, it probably forms about 8%. So 1 in 6 consultations of chronic pain are due to neuropathic pain. The traditional way of thinking about this and managing it is through a multidisciplinary approach. We can offer some medicines, some psychology, some physiotherapy, and traditionally we've followed the World Health Organization ladder for analgesia. So, but what we need to add in are the tricyclics and the SSNRIs and the calcium channel blockers in the form of the pentanoids. And it's really much worse than chronic pain. Chronic pain is bad, but actually neuropathic pain reduces your quality of life much more than anything else. Your activities will really fall, your work status goes, you're more likely to have depression, anxiety, and it's gonna affect your mood and your sleep. So it's really important that we manage this as optimally as possible. And what does it cost the health service every year, or the wider community? Here's just a little sort of guesswork on how much it costs, but it's around £9,000 a year, with sick leave accounting for the majority of that, or half of that. So it's a significant burden within society. Just remind you of what the symptoms will be. It'll be burning. They may feel a prickling sensation. It'll be intermittent attacks. Feel numbness, that pressure feeling that we've all said. The signs that will be there for you will be thermal signs. You may notice that there's a little bit of difference in hot and cold, since if you feel their limbs. So those are the things to sort of look for initially. And this is, it should be really easy to sort of manage. We know what's causing it, surely. There's nerve damage, there's these increased factors, that leads to them being absorbed into the axon, and that leads to increased expression of other neuropeptides, that leads to sensitization. And what's happening centrally will be an increased amount of NMDA, which is where ketamine's thought to work, and that can lead to centralization. So if we know all this pathology, why is it difficult to manage? Well, I think that comes back to our teaching. We're initially taught about circulatory system, we're taught about the pulmonary system, the skeletal system, muscular system. And traditionally we're taught about the nervous system as such, but actually there is this other system, the endocannabinoid system, that we sort of need to address and help. And this next slide shows where all these receptors are. So they are everywhere. CB1, CB2 receptors, like throughout the body. We don't really know where CBD actually works. THC is a partial agonist at CB1 and CB2 receptors, but there's a lot more work to be done here. And this is just a quick summary of where the receptors are and how they can influence things. I won't go too much into that because that's been covered in previous webinars. So just to go back to neuropathic pain, diabetes is a massive cause of it. And just to remind you that at diagnosis, type 2 diabetics, 50% will have some form of neuropathic pain, and that may be as a peripheral start of a peripheral neuropathy. And the problem is that it doesn't matter how you manage their sugar controls, that always gets worse. And I see lots of these patients who've had falls, who've really fractured their femurs, or really serious fractures where they're in a cast for 3 months, and also see the other end of things where they're getting amputations because of vascular insufficiency. MS is obviously a huge central neuropathic pain syndrome, and there are a few others listed there. I'm not saying that cannabinoids can help with all of these, but they're just some of the neuropathic elements that we come across on a day-to-day basis. So what did the NICE guidelines say? So what's in our arsenal in order to help? We have amitriptyline, duloxetine. I have to say, with regards to diabetics and neuropathies, duloxetine I've been really surprised about. We have the pentanoids. My GP colleagues who I speak to hate it when patients go to the pain clinic and they come back with either more opiates and more pentanoids, because the pentanoids are becoming a real problem within the community and with regards to addiction. So second line is either switching between these. NICE doesn't like us using 2 of these drugs, but actually that does often happen. We can consider tramadol and capsaicin cream if necessary. To me, that's not. We don't have a lot of options for a lot of patients there, and often they will go through all of this and not have any result from this, and that's a lot of the patients I'm seeing right now through the clinic. So why aren't they working? What is the number needed to treat for these? So how many patients do we have to give this drug to get at least a 50% decrease? So these numbers are quite harsh, but you can see that I often see fibromyalgia people on a pentanoid, and you can see that it's about 13 or 22 you have to treat in order to get a 50% reduction. Surprisingly, here is venlafaxine. It says it's 3.1, which would make it better than amitriptyline, but amitriptyline in my mind is the best anti-neuropathic we have in order to treat pain. And duloxetine is surprisingly 6 to 8, but I think they're not including the diabetics, or just specifically the diabetics in that group. But I was quite shocked that actually a lot of the drugs that we have in our arsenal don't really work. You're going to have a huge percentage of patients where they just haven't helped, and it's not surprising considering the numbers there. We've had some false comings. Nortriptyline was considered, it's going to really help. It's another tricyclic with a lot less side effects. But actually, Cochrane review in 2015 said there were other drugs that worked better, and it had too many side effects. So we just never get to prescribe that anymore. There are risks with gabapentin. This is from the MHRA that said actually gabapentin is associated with respiratory depression, even without opiates. So if you have elderly patients where they have respiratory system problems, I'm not just talking about now, but in the past, such as COPD, then we have to consider not using these medications. And what about pregabalin itself? Well, it works in post-hepatic neuralgia or diabetic neuropathy, but if they have a central neuropathic pain, then or HIV pain, then it doesn't really work for that. So we can't use it for that. And again, it's just limiting our options for medications. So I just want to give you the latest research. This is from Germany, and Germany are a little bit better than us at producing our registries for pain. At my Access Clinic, we are able to put all our patients within a database in order to get evidence coming forward, and we're hoping to do a similar registry with them where we're able to prove the outcomes of the patients that we get. But overall, he did this study. The left-hand side just very simply shows that pain scores actually went down, which is a real surprise for pain. Anything that we normally use, we normally measure what the patient can actually do as a measure of how much benefit they're getting, and that's more on the right-hand side. They're all research validated tools to say that their sleep got better, they're able to walk more, they were physically more mobile, they're able to do more household chores. And that's what the top right shows. The bottom right shows that actually they measured about 9 factors for this, and actually most of the patients, the black bar, were actually getting 6, 7, 8 or 9 different individual benefits from cannabinoids. This was particularly with Sativex, which is a 1-to-1 ratio medication. The other thing that it showed is the first column is actually about nociceptive pain. It showed that the medication Sativex didn't really reduce their other analgesia, either non-steroidals or strong opiates. In a mixed picture, there was so a mixture between neuropathic and nociceptive pain. There was a small reduction in medications, whereas in neuropathic pain, there was a real strong reduction in their strong opiate analgesia. And not only that, if you look at the bottom column there, the demand for rescue analgesia, actually that really went down as well in the neuropathic group, as well as a little bit in the mixed pain group, and not really in the nociceptive group. So that sort of is our latest evidence with regards to neuropathic pain and opiates and the benefits you can get. The other thing just to remind you of is how the question you get is, what about dependence? How dependent are patients going to get on this? Well, if you look on the scale here, morphine, nicotine, heroin are on the top of the scale. Cannabis is somewhere between alcohol and caffeine. So as safe as we can make a medication, I think we're somewhere near that. So what's happening in the UK right now, and how can you influence what goes on? So since November 2018, it's been legalized within the UK, but actually there's been very few scripts. And the reason for that is that there's been a lot of hoops in order to jump with in order to make sure a patient can have this medication. And that may be they've had to be on 2 previous neuropathic forms of medication in order to be allowed to have it, which is fair enough at this stage. But across the world, and you've probably seen this with other drugs previously, where the Europeans will take one view and the Canadians will take one view and the Americans will take another, and that's what's happened. So Canadians and Americans have cannabinoids higher up on their ladder, whereas the UK is right at the sort of top of the ladder at the moment. You'd have to jump through a lot of hoops in order to get it, but that will change in the future. Fingers crossed for that. And just to remind you of what happens with the shared care issues coming up, so what we would do is I would prescribe the medication on day 1. We'd review it at 28 days, so month 1, month 2, and month 3. Hopefully by that stage we've stabilized patients, and then they can be handed over back to GPs in order to get shared care. That's not the process yet, but that's the dream. And the only adjustments I feel you're ever going to have to make is probably you're going to have to lower the dose rather than increase the dose going forward. So that's just a crash course through cannabinoids. I think I've gone a minute over, but if you want to get in contact with me, please do. I'm on LinkedIn, Twitter, and please feel free to email me. I'll be very happy to answer any questions, or even send you the slides if that's what you wanted. So I'll just hand over.
Thank you very much, Sunil. I'd like now to hand over to Lucy for the second presentation. We've already got lots and lots of questions coming through, so we will be going through those shortly. So if you want to switch yourself off, Sunil, and Lucy can switch herself on, and we'll push on with the next part. Are you there, Lucy?
Yes. Can you hear me?
Yeah, I can hear you. You might want to click your camera as well so we can all see you.
Okay, yeah, that would be a good idea. Sorry.
Great, thank you, Lucy.
Hi, I'm Lucy, and I'm a medical cannabis patient. And firstly, I just wanted to say thank you so much for your time this evening, and particularly anyone working in healthcare at the moment. Thank you so much for all your work, and thank you so much for making the time to be here. I'm a medical cannabis patient, and today I'm going to be talking to you a bit about my treatment, how medical cannabis came up as an option for me, the effect it's had on my life, and what I actually take. So I will start with where my treatment was before I started medical cannabis. I have a condition called Ehlers-Danlos syndrome, which basically means that my connective tissues aren't created properly. The collagen is too flexible, so my joints and my internal organs are just too lax. And so I'm 20 now, but this has caused me chronic pain since I was about 10 years old. As it causes me to have dislocations with very little to no trauma, so I can yawn and dislocate my jaw, or brush my hair and dislocate my shoulder, which has always been an absolute nightmare to manage. It causes muscle spasms, neuropathic pain down my legs particularly, bladder spasms and retention, and digestive issues, including gastroparesis, so my digestive system is much more slow and sluggish than it should be. There is no treatment plan as such for Ehlers-Danlos syndrome. It's not very well researched, so everything is just about symptom relief and improving quality of life. And for me, before medical cannabis, that was basically opiates every day from the ages of 13 to 19. Started with weaker opiates such as codeine in increasing doses, and then by the time I was 17, I was taking fentanyl, and they did very, very little. That did very, very little to actually manage my pain. I was never in no pain at all. I was never felt significant relief, and it made me feel like a zombie. And I didn't realize it because I'd started them so young, and I didn't realize what was happening to me. But it really made me not in touch with my emotions, not really understanding myself. And so, yeah, and alongside that, the opiates had a very, very destructive effect on my digestive system. And alongside my genetic connective tissue disorder, it really upset my digestive system. And I ended up on IV nutrition after a range of feeding tubes from the age of 16 to 19. And alongside that, particularly because the opiates made me feel so sick, I'd have to have antiemetic injections multiple times a day. And so my doctors would just try absolutely every medication in the book in every form, but nothing. I never had symptom relief. And because of this, because I became so weak from all these medications, and I spent a significant amount of time in hospital, I lost so much of my strength, and I was a full-time wheelchair user as a result of my dislocations and the weakness. It was just really a recipe for disaster, and my health was really, really poorly managed. And that all started to change when I was introduced to cannabis. And before the end of 2018, I had never heard of medical cannabis. I'd never used it recreationally. I'd never even been around it at all, to be honest. And I dislocated my jaw quite very severely. I had surgery, I had Botox, I had benzodiazepines, I had opiates, literally all sorts of things to try and get my jaw back into position. But because of my underlying condition, it just wasn't happening. And my NHS pain specialist, he made a recommendation to me of a cannabis-based medicinal product and tried to prescribe it. It was something he had never done before, and it wasn't something he really understood at all. But he had seen me get so sick and sicker and sicker and sicker. He'd treated me since I was 13 years old. He couldn't increase my dose of fentanyl anymore, yet I was sitting in front of him crying my eyes out, and he had to do something. But as all NHS prescriptions have since the law changed, the funding got denied immediately. And I was at such a point of desperation, I sourced it illegally on the black market at first. And it very, very quickly, once I had figured out the correct ways of taking things, and it made a significant difference to my life. And then about a year ago exactly, the private clinic started to open up across the UK, and I was very fortunate to have the support of my family to get an initial prescription, which cost £1,400 for the first month, and that has now reduced to about £900 a month. But as I'm sure you can imagine, that just is not sustainable for myself as a student. But that's why initiatives such as Drug Science's Project 2021, which will get aiming to get 20,000 patients onto subsidised medical cannabis registry, will be a real lifeline, so that people don't have to resort back to the black market to get their medication when they have no choice just because they can't afford it. So the impact that having this medication has had in my life has been so significant. Very quickly after I got into the correct dosages and the correct strains of cannabis, I realized that all the medications I had been so dependent on from a very young age, the opiates, the antiemetics, the benzodiazepines, actually had done very little to manage my pain, because I realized now what pain relief felt like, what it felt like to not have pain, and caused such significant side effects, which I didn't even really quite acknowledge until I was off them, because I had been on them for such a long time. Stopping those medications meant that my digestive system actually started to recover, and the correct cannabis-based medicines really supported that. And for the first time in many years, I have a healthy BMI, which no one ever really expected would happen, and is brilliant and makes me so much stronger. I also sleep better than I ever have done. I used to have crazy insomnia, and then the next week I would sleep 20 hours a day. My sleep schedule had no routine to it, no anything, and it made me feel so much worse. Whereas now I sleep a solid 8 to 10 hours every single night, and it's incredible, really. Further, I've also been able to do physiotherapy and exercise, and I'm now learning to walk, which is insane, because for years and years I knew, and my doctors knew, that strengthening was the best thing for my condition. Strengthening up the muscles when my joints are very, very weak is what I have to do to then prevent the dislocations. But before I had access to this medicine, I was in so much pain that I couldn't even sit up in bed without dislocating a shoulder, and then I had no rescue from that. I had no relief. And so starting a physiotherapy program just was never successful, because it just couldn't be. And now I'm also doing a science, technology, engineering and maths undergraduate degree, which I never really thought that I would be able to do, but that's something that's really exciting, alongside doing advocacy work for medical cannabis. But I think it is really, really important to state very clearly that this is not a cure. Like, I still have Ehlers-Danlos syndrome, and that's not going to go away, but I now have something that improves my quality of life too, which is just all, with a condition like this that causes so many different multi-systemic things, some sort of pain relief, some sort of improvement to your quality of life is a miracle. Even though it's not a cure, it's not a whatever, I'm still sick, I still use crutches, I still use my wheelchair on a bad day, but it's unbelievable compared to what my life used to look like and what my future was going to look like beforehand. And moving on to, I just thought it'd be really useful to say exactly what I take every day, because medical cannabis can mean different things to so many different people. So I take 50 milligrams CBD 3 times daily as a baseline, and then I will take between 5 and 10 milligrams THC, depending on symptoms and depending on what's going on, 3 times daily alongside that, and they work well to balance each other out. It was really important for me to find the correct terpene and cannabinoid profile for my needs. If I take the wrong strain, the wrong type, too much THC, I will get quite anxious. I can even have a panic attack and that kind of thing. So it's really important to find the best thing. And then alongside that, for when I have acute pain episodes, such as a dislocation or a spasm or being sick, for example, I will have inhaled 13% THC flower is what I am prescribed for acute symptoms. But yeah, I think it's really important to know that no one size fits all in this medication. And to me, that has been why it has been so successful. It's because I can tailor it to my needs, and I can tailor it to my symptoms, and I can find what works for each thing. And that is so unique. And so I can switch it about. I can increase my dose and not be worried about the effect, about toxicity, about overdose. And that's it. The flexibility that it brings is really, really important part of the medicine. So that's everything that I have today, but I just wanted to say thank you so much for being interested in medical cannabis to chronic pain, because chronic pain conditions are such a nightmare to live with, and the current options just leave patients begging for more and more medications that just don't work, or that was certainly my experience. And having alternative options, whatever might work for people, we need to understand more of. And I really hope that as things move on, patients can have open conversations with their practitioners about cannabis and not feel stigmatized and not feel judged for what they're doing, and to be able to tell people truthfully why they take it. And I think understanding the medication is a brilliant place to start. So thank you very much. And that's everything.
Thank you, Lucy. That was excellent. It was really good to actually see and to hear how that's impacted on your life. And this is obviously something that's still, as Sunil's pointed out, very new in the UK, and we perhaps have lagged somewhat behind the rest of Europe, as well as the rest of the world. There are lots and lots of questions, so I've got some for both of you, if that's okay. We'll work our way through them. So one of the things that's very interesting there, and was picked up by quite a few of the audience, is there doesn't appear to be an increasing tolerance in the same way that you would get with opioid medication. And you've said, if anything, almost sometimes the dose will decrease. Do we have any idea why that might be, or has that been replicated across a number of studies?
That we don't know why. That's the first instance. I can't give you that answer, and that I think we will discover that in the future. I think the reason for that is I've tried to speak to as many professors of cannabinoids as possible, but if you try and really pin them down on what exactly is happening, they can't explain it. I really try and hammer them down to explain the process. I'm an anaesthetist by background, so we love to know how things work. But we don't. We don't know we really don't know. There are probably more receptors that we don't know of. We don't know about the interactions between all of the cannabinoids within the plant extract and how the terpenes influence all this. So there's a great deal of research still to happen. We will find out, but I don't know why that's happening right now. But to me, that's reassuring as a doctor that I'm not giving more medication. As Lucy has said, that your fentanyl dose just goes up and up and up, and it does nothing, and it just gives you that hazy feeling, and you don't know you're in it until you're out of it. But those complications aren't there in my mind with the patients, and specifically from abroad, they're not experiencing that.
And that very much fits with your experience, Lucy, that once you got on an optimal dose, that's really been it, and you felt fairly comfortable, albeit that you have to have extra for acute episodes.
Yeah, it does. It is like that I have reached my point, my right dose, and my body has adapted to that, and I don't feel like I need more. It doesn't feel like my pain starts to come back. I do need to sometimes strain swap, so I'll need to change the oil that I have after a few months, because my body kind of gets used to that. I can become tolerant to, but I never have to then increase the THC dose. I just have to change the actual product. But that's all I've experienced.
Mm. Yeah, I suppose perhaps, from obviously from a GP's perspective, one of the issues here is there are so many different strains, there's so many different concentrations, and it's quite complex. I mean, what would you look for in an optimal dose, and what was the information, Sunil, that you would use to establish that that is the right dose?
So at the moment, a lot of patients know what that is. They will be telling me what they want. If you've got a totally naive patient to cannabinoids, you normally start off, as Lucy has actually, with a CBD higher strain during the day, maybe 2 or 3 times a day, and then a THC strain at night in order to help your sleep. And that's what probably 80% of cannabinoid prescriptions are. So although it sounds very complicated right now, 80% of them will be relatively, inverted commas, simple, where you will know how much CBD to give during the day, and you will know a little bit of THC at night. Lucy's probably slightly different in the sense that she's taking a little bit more THC for her acute episodes, and vaping that, but that's fine. I think in most conditions you will have a background level of oil, and that will be it. That you won't have to go above and beyond that.
Okay, so and obviously it's quite a complicated process at the moment in the UK to get hold of a cannabis prescription. So if we sort of say somebody feels that maybe something would be of benefit to them, and they approach their GP, or if a GP, whilst talking to a patient, feels that they may benefit from this, what's the process that we would go through?
Well, right now, if it's MS spasticity, or if it's Dravet syndrome, then they would go to either, well, probably a neurologist in either of those 2 cases. If it's something outside that, then they would be referred to a cannabis clinic. They are all private at the moment, and they would then go for an assessment there. That assessment process involves all the information you can get from the GP, just to make sure that 2 previous anti-neuropathics have been tried. So if they've tried amitriptyline, nortriptyline, gabapentin, or pregabalin, and venlafaxine, duloxetine, any 2 of them, then they're then eligible for the process. The British Pain Society do say that if you've previously been on cannabinoids, then you can be referred for medical cannabis as well. So that may have to be taken into consideration. But I suppose you're talking about somebody who's not previously taken it.
Yes.
That is the process right now. We are governed by that right now, that we have to prove that they've tried these 2 anti-neuropathic medications previously, and then we can put them forward for the consideration. The process from there about getting the medication is being smoothed out presently, where hopefully there will be stock within the UK, so that process should be relatively seamless going forward. So they should be able to get it in a week or 2 from there.
Okay. And there's lots and lots of people saying thank you very much for your talk, Lucy, and how much they appreciated you having the time and the effort to talk to us. One of the couple of questions relating to that is, one is, when you say you change strains at times, do you ever then go back to an original strain and have a benefit again, or are you constantly swapping from one strain to another?
I can go back generally if I found some. Yeah, so in the past when I've had prescription oils, for example, I would be on a prescription oil for, it varies, usually around 3 months to 6 months or so, through a while. I find with flower I have to change that more often, because I don't know why, but yeah. But yes, generally if it's working wise for me in the terpene and cannabinoid profile, then yes, I can come back to it later, but my body just needs that time to reset, and I can't wait to the time that we had research to understand why these things happen in whys, whatever. But I know that it's not just me that experiences that either.
Yes, okay. And before, when you were having to source cannabis before it was prescribed, what was the process for you then? Were you having to, were you buying cannabis on the black market, or were you smoking it? Were you ingesting it?
So I was buying it on the black market. So I was lucky enough that I had a source who was also using it for medical purposes. So it could tell me what it was basically, and I could trust that it was what it was. But having said that, I was then making it into my own oils, which worked ish enough, but getting accurate dosing in that way is very, very hard to do at home by yourself. But it is viable for patients who have really no other option. But no. And then I was also vaporizing it as well, so I wasn't, yeah.
Yeah, it does seem obviously that there's a plethora of conditions that we can use medical cannabis is used for, and there's quite a lot of nuance between the various doses of CBD to THC for different conditions. And of course, if you're not having an approved medical product, that must be quite difficult to make sure you're getting it right all the time.
Yeah, it's very hard for patients because, I mean, when you're really ill, you're not really up to learning about how to titrate a dose and what parts of it you need. And so really patients should be able to go to their doctors and say, hey, I'm interested in this. Can you increase it? Can you just start it on me? Whereas at the moment, patients are just having to try and learn it and research it and figure it out themselves, which really isn't how it should be when it's a medicinal product.
It's quite challenging as a GP when the person comes in and they know a lot more about the subject than you do. But we're all going to learn somewhere. We're going to start somewhere, haven't we? So, so I'll come back to you a little bit. I mean, why does medical cannabis cost so much at the moment?
I'm not a financer. I don't know. I think I think one of the things I think Lucy's paying a lot of money for what she's getting, actually. Usually the cost of it is coming down as production increases, as these loopholes, as the process of getting it into the country becomes easier. I think the cost will come down. It's like anything that's new when it first comes out. The process of setting up a lab is really expensive for the producers that are doing that. They are producing medical quality cannabis, so as soon as they're able to upscale that, I'm sure that will lead to a reduction in cost. But that's not really my forte at the moment. My forte is helping patients getting access to it, and then building the evidence. And for me, that's the important thing.
I think also a big thing that adds to the cost is the fact that it is a Schedule 2 medication at the moment. So when it's imported, it has to be done under lock and seal condition, and because it's being imported from a different country, it adds a lot for the pharmacies, and then the pharmacies add their own fees to it. And by the time that the bill gets to the patient at the end, it can be much, much higher than what the medication would be in the country that it was sourced in. So by the time it gets to us in the UK, it just gets exponential.
Yeah. The UK actually makes a lot of medical cannabis and they export it. They don't keep it in the country. We're one of the biggest producers in the world. So we're giving it to other people and not using it ourselves, which is even more madness.
Yeah. So somehow that doesn't surprise me. So Sunil, when you're talking to a patient about how they use this, obviously we've got people who are vaporizing, people who are ingesting, and different processes. Is there sort of harm reduction advice you have to give, or any of this? Is this potentially dangerous to people? Are there risks around any of this? How would you suggest to people that they were to use the products?
So at the moment, what we offer is an oil-based medication. So the profile of all this is that they're getting a background medication that's lasting a long time, as Lucy is doing. And if they do get an acute exacerbation, then they need something that works a little bit quicker. And vaporizing is a great way of doing that. In the UK, that's the flower itself is a little bit more difficult to get, but that will change with how things go forward. Vaporizing wise, you have to be very specific on the device that you use and what you're using in order to the cannabis that you're using. So those two things have to be governed. So the problems that have been with vitamin E in the States have all been from oils that weren't produced from a medical grade product. So those risks are then therefore minimized as much as possible. But I think those restrictions are coming in. At the moment, there's been a bit of a free-for-all for anyone who can produce it under the foods license rather than under a medical license, and that's going to stop towards the end of the year or next year. It's probably going to be end of 2021 now. But those safeguards are coming in.
And so, I mean, and do you see a building of a groundswell in the UK? I mean, how long do you think it will be before it actually becomes a regular and almost commonplace part of our therapeutic armory?
So I think if we go with the experience of abroad, that's sort of a 5 to 10 year time. In Canada, it was legalized about 10 years before it became commonplace to how it is today. And I anticipate the same thing will happen here. Maybe we'll be able to shorten it to 5 years with stories like Lucy and some of us trying to prescribe and trying to get patients better. And as we build the evidence, then I think then we can go to peers and say, hang on, this is what we're doing, this is the evidence we've got, we need to change something in order to be able to get it to more patients.
Okay. Yeah. And I suppose that the issue for me as a GP would be still that it does seem incredibly complex process. And I can imagine that it would almost seem easy to say to people, can't you just go and buy it? It'll cost you less money, and I won't have all the hassle of dealing with it. And quite frankly, the police are probably not going to prosecute you. And I know that's wrong, but I just think at the moment there's that little hurdle of, what's coming across as a relatively complex medication compared to opioids, which obviously are not that helpful, but they're quite easy to titrate and they're easy to access. Even if they're a controlled drug, they're simple for us to prescribe.
I mean, my answer to that is that you've got a medication that can help somebody, and I think it's up to us as doctors to learn as much as we can about it and learn how to use it. I know it's very difficult during everything that's happening to sort of be in a position to do that. But honestly, it's not that complicated. And sending somebody to in essence, drug dealer, where they're able to mix it with fentanyl, they're able to grow it with heavy metals, they're putting pesticides on it. I'm not comfortable in doing that. I'm more comfortable giving something that actually I know is of medical grade. I know I'm prescribing. I know exactly how much I'm giving some control to the patient. It's not just me here, it's actually the patient that's able then to go up and down on their dose. That's much more comforting for me than saying go to somebody else and do it. And that's the experience of doctors in Canada and in the US as well. So it seems difficult now, but it won't be difficult in the future, and we just have to lead that change within within our peers.
Absolutely, and I agree entirely with what you say there. It is something that we need to move forward, and I'm certainly far more comfortable with people taking a medication that would be, that's been prescribed, and I know exactly what the doses are, and they're being kept safe from the significant number of other harms that could come that way. As I say, I think the next step is to get that availability and get the cost driven down. And those of you who were listening to the last webinar we did with David Nutt, and Lucy alluded to this as well, the project to get, is it 20,000 people, Lucy?
20,000.
Yeah. People, and then the research follows, and that's always the issue, isn't it, at the moment? You adopt something early, and you're a little bit on a limb, but then actually the more people who do that, the more things come in. There are other questions, and we're not going to be able to go through them all, but for everybody, I just want to say that there's been a lot of very positive comments on both of your presentations, and I think people have found them very, very helpful. Those of you who are listening, you will be sent a link for this website, so you will be able to log on and look at it again. Sunil's kindly on his slides put his details there, and copies of the presentation can be made available. I'm sorry if you asked a question that we weren't able to answer, but I'm sure you'd all wish me, wish as well to Lucy and Sunil for what's been a very, very entertaining session, and enabled us hopefully to take our minds off some of the other issues that are troubling us all at the moment. So once again from me, Steve Brinksman and SMMGP, thanks to Lucy and Sunil, and I wish you all a very good night.
Thank you.
Thanks very much.